disease. It's a disease of the brain. And, you think of somebody who drinks too much or takes drugs, that some people think that you can just stop. It's not one of those things you can just stop. It's kind of like cancer, that you need treatment for it. You need to be cured from it. You need follow-up care. So I think what I want to kind of set the table here is just understanding what addiction is and what opioid disorder means. And I'm going to ask John maybe to talk a little bit about that.
Well, I think the first thing we want to do is recognize that it affects everybody. It affects people of low income, medium income, high income, people of all races, all backgrounds, that there's nobody's safe from addiction. The other thing I think that we skip over a lot is the number of people that it affects, not just the person that affects, but the ripple effect on families and businesses. And I think that we want to make sure that we get to that at some point today, that the human cost and the financial cost in the workplace as well, I think, is important to discuss. And what we have to realize is that many people get addicted to things, not just through recreational use, but also through having injuries at work, surgeries, things that,
prescriptions.
Yeah,
Legal
prescriptions that
prescriptions.
everybody does. And I often say, we have an adolescent program in South Boston called the Cushing House, and we've done probably 1,000 intakes since 1999. And I always say, nobody's, when we do the intake, we ask them age of first use and drug of first use. And I can tell you that nobody comes in and says opiates is their first use.
Marty, what are but we should say the Mayor's Office of Recovery Services is in your jurisdiction, Health and Human Services. Obviously, you're dealing with this every day. What are we talking about in terms of drugs? I mean, everybody can recite fentanyl and opioids and stuff, but it's broader than that, is it not?
Yeah, it definitely is, and that's why I thought, even though we're talking about it from an opioid epidemic, I mean, we're talking about folks dealing with substance use disorders, and that continues to still be alcohol. It continues to be, and now we see more meth. On the street, people dealing with and using meth, heroin. So we talk about opioids because that's what's sort of in the news and what's front and center, but what's come before and what's come after continues to impact folks every single day. So the reason that I think it's important to lift it up is that it means it's complicated on how it plays out in the street, how it plays out in treatment programs, how it plays out in terms of what kinds of resources people need and treatment beds. So it's definitely more complicated than the opioid itself, or opioids as the epidemic, but that's why we really need to lift up how complex it is.
It's a disease of progression as well. Yeah. No one starts out being drug addicted or alcoholic the first day. My alcoholism started with drinking a couple beers, and at first the trouble didn't happen, and over time it became a disease of progression, where you're drinking to kind of drown out the feelings, and you're drinking to excess. And everyone, at the end of the day, it's kind of like, I say this is an inside game, where the recovery comes into play is you're just defeated and devastated. Not everyone gets it either. So it is progression. So whether it's opioids, somebody gets a prescription of OxyContin or whatever it might be for their back or for their arm or for their leg or for their tooth, they take one or two, and then all of a sudden now it mounts into from OxyContins to something else to needle in the arm, and progresses from there. Now we're seeing fentanyl, crystal meth, all the other drugs on the street. Same for alcoholics. Anyone who's listening today, we'll say this a couple times, but anyone listening today, if you are looking for help and you're listening to this story, listening to this radio show today, you can call 311 City of Boston. We will be there for you to help you. If you're outside of Boston and you want to call in, it's 617-635-4500.
Before we move to, I know John wanted to comment on this too. We have spoken to a lot of doctors, people who run programs around this. One of the first topics that comes up in terms of the current state of affairs is the stigma issue, and that while it's being addressed and maybe it's mitigated to some degrees, I have to say, we usually don't compliment you on your normal segments here, but let me just say, I'm amazed at how open you are. When you spoke at the Democratic National Convention, what was your opening line in that speech?
I'm Marty, an alcoholic.
So why do you do this?
Because it's important to be able to let people know if they need to get help. When I became a legislator in '97, I quickly jumped to this issue, and I just felt Kevin Fitzgerald, who was the rep from Mission Hill, used to introduce himself as Kevin Alcoholic. I mean, I'm a politician, he'd say. And I thought that putting it out there allows two things. Number one, if people are looking for help, they'll come find me. And number two, understanding, and I wasn't really thinking of the stigma at the time, but the stigma of it as well, that in '97, even when I was on the Gavin board, with the Cushing House, parents didn't want to tell people their kids were addicted. Families that lost loved ones would say they had a heart attack or some type of something going on. Over time, that's changed to some degree, and people are more open about their recovery, and people are more open about their families are more open about.
And that
recovery.
helps everybody else.
It does help everyone else because if you have that support network and you're a parent and you're struggling, you don't know where to go. You hear that there's a program called Learn to Cope. You hear there's programs out there to help you, that you're not alone in this. Because I think a lot of times, alcoholism and drug addiction is isolation. It's a thing of isolation. You isolate, and you don't talk about it, and you kind of isolate, and the family isolates, and they don't want to talk about the problem in the other room. And I think by having it out there, you know that it's okay to talk about it, and it's okay to address it, and it's okay to try and reach out, get the help you need to deal with it. Whether, like John said, whether it was the family disease, which it is, or it's the individual disease, it's really difficult, and I just think it's important.
By the way, as I said, we're going to take your calls. They are going to take your calls. 877-301-8970. Before you ask what you're going to ask, can you follow up on what the mayor just said? Because you have talked on the air repeatedly about how people have started in obituaries.
Yes.
Which is a really, but go ahead.
Well, I did a couple of stories when I was doing columns for the Globe about people that they've started to say in their obituary it's often their child, 25, 28, 35, succumbed after a long battle with addiction. And I wrote a story about a woman up in Salisbury Beach whose son she spent tens of thousands of dollars, and she was a middle-class woman, had a nice house in Salisbury, nice house in Massachusetts too, and spent tens of thousands of dollars to get her son help. And she talked about how much he wanted to stop, how he was in rehab, and was doing really well for 7 years, and then comes home to his old neighborhood, hooks up with his old buddies, gets high, and dies by accident. I mean, and he started this after an injury, like the mayor talked about. So as you talked about, John, we know that there are people that are really struggling, that you see the people down by Mass Ave and Melnia Cass and stuff, but there's all sorts of people who are, I guess you could say, functioning. They're kind of going to work and kind of being parents, but they have this big, huge addiction problem. Middle class, upper middle class, wealthy people.
But I want to gloss over the original point. Is putting it in an obituary rather than saying my son died or daughter died after a long illness is another variation on what you have done, Mr. Mayor, is being honest and
coming
open
out of the closet.
which I think does make a big difference dealing with a stigma issue.
Can I add a piece about the stigma
This is
thing?
Marty Martinez.
That I think is important, which is stigma about what we experience ourselves, but I also think the history of how we've dealt with addiction and drugs and crime, I think also stigmatizes how people think about it. And the reason I lift that up is I think, in communities of color, we will often hear, references to what had been, the war on drugs and how we dealt with addiction in the past versus how we think about it today around a disorder and a disease. And so the reason I lift that up is I think it can also feel like we're battling stigma now, but we didn't really, the stigma then was sort of okay to say people that are facing those issues or those addictions, those were bad people. That's why we had the frame we have. So I just think when we think about stigma, it really is the biggest barrier to getting people accessing care, and it comes in different forms in different communities.
Well, since you brought that up, I was going to hold questions for a few minutes. We just got a tweet from a woman you were on my television show with last night, Professor Tina Opie from Babson, who asked a question, Marty Martinez, that relates to that. What happens to people with substance abuse problems who were historically criminalized, many still in prison? How do you address that?
Yeah, I mean, I think there's programmatic ways to address it, right? I mean, I think part of that is reaching people that are incarcerated through programs and services to help them get not only treatment there within the House of Corrections, but also as they transition out into the community and connecting them to providers and services. I think it's really important. I think state data tells us that en masse, that people that are recently released from incarceration are much more likely to face an overdose or a fatal overdose. And so I think that's important, but I think this is exactly what I'm talking about. I think the fact that the criminalization of it then has created a whole notion that people feel like they can't get help because they got in trouble for it, versus people getting the resources they need to find a different path. But again, I think it's all those pieces trying to figure out a better way forward.
You know, when we get to solutions in a minute, you just mentioned about treatment in prison, but we talked to Carol Rose, head of the Civil Liberties Union here, about a lawsuit they filed in December because the federal prison system is putting limits on opioid treatment, putting a 90-day sort of cold turkey kind of thing, seeming to me as a layperson totally misunderstanding the problem and the cure, John.
Well, I think the law here in the Commonwealth is, that they recently passed last year, was so that when somebody goes into incarceration, they have access to medicated assisted treatment for the first 90 days to make sure that nobody is instantly detoxed and has withdrawal issues while they're going into incarceration. And then again, they have an opportunity to sign up for MAT 90 days prior to their release. So if people
What's
feel
that?
they need the extra.
MAT, what's that?
Medicated assisted treatment,
Okay.
so it could be the Vivitrol, Suboxone, or Methadone. So they're trying to have them access it 90 days prior to release.
So before we get to calls, we have calls and we'll get to them in a second. Can we talk for a couple of minutes about what we are doing in Boston? You may think things are working, not working. Obviously, we talked to you about the whole Melnia Cast situation, and there is a Melnia Cast 2.0 from what I understand, Mr.
Well,
Mayor.
in 2014, we started the Office of Recovery Services. We're the first city in America to have an office like that. We started to make investments in counseling, make investments in treatment, make investments in getting people into treatment, really focusing on, rather than just kind of patchworking the situation, really taking a deep, comprehensive dive into addiction services for all of Boston. Melnina and Mass Ave people think it was created after the close of Long Island Bridge, that kind of what was going on down there. It was going on in that area long before Long Island Bridge closed, let's be honest. Anytime we went down there. And the reason why there's so many people down there that are addicted, there's a couple reasons. Number one is Long Island Bridge adds to it. Closing of Long Island, losing the services on the island adds to it. The services that are there currently, there's a lot of detoxes, and you have the city hospital, you have healthcare for the homeless, you have methadone clinics, you have all the services that people are struggling in different ways, in different aspects of their life. They're struggling, so it attracts them to that area. And then you have people who just go there on a daily basis because they see other people there. And then you also have, in some cases, when we're trying to do this, is weed out the drug dealers who are there as well, preying on people. So it's almost like a bad storm, but a perfect storm that's happening down there. And you know, when John opened up his comment here, what we see in Melnina and Mass Ave is happening in individual homes all across the Commonwealth of Massachusetts, across the country. Now, you might not see it because it's in somebody's home and they try to hide it, but it's happening all across. So it really is talking about, in the Office of Recovery Services, getting to the heart of the disorder, getting to the heart of the disease, getting to the heart of that, and how do we try and help people one person at a time get onto a road of recovery. And that's ultimately what our intention is. You know, we've added in the last, since 2014, I know 25, maybe 20 counselors. We've added outreach workers in the street. We've increased our AHO program, which is detox. We work closely with the Gavin Foundation to get people into their detox, in their holding, in their halfway houses. We're working with other organizations and nonprofits. We're working with a whole bunch of different people. We're working with the state representative, John Santiago, who I was talking to
Who's
earlier.
also a doctor.
Who's a doctor. I mean, John is in his first term and has an understanding of the issue as an elected official now on how to deal with the issue, but he also understands it as a medical disorder in the brain and the development of the brain and the damage to the brain. So we're working with John. We're working with Aaron Mikowitz, who's a state rep from the North End, who's been helpful through the budget process, and a whole host of other folks. So we're going to constantly, you know, not to get off track here, but what you see out in the street is why I think we're here today talking about this issue, that the face of addiction is the people on the street, people in prison, people in recovery. There's a whole bunch of us.
Can I just add to this piece for the mayor that, you know, to give you an example of that, every single week, and we track data and resources in terms of what we're doing. Every single week, the outreach team that the mayor's put in place, as well as the diversion team through the Boston Police Department, is referring roughly around 70 individuals every single week into some level of treatment in that neighborhood. And so it's important to think about that many people get referred into treatment many times. It takes many, many times for some folks to actually get on that better path. But to get one person into treatment is a long process. To build relationships on the street, to build connections with them, to have them trust you, and to have them connect to a resource like the Gavin Foundation or others who are going to be able to connect with them. So
And
it's
wanna
just
go
important
in.
and want to go in. Right.
Well,
You know,
isn't that
but
one of-
I'm sorry,
Isn't that
go
one
on,
of the
Margaret.
things that you read about alcoholism, which you would know about, Mr. Mayor, that you kind of have to get to a rock bottom
Listen,
point where you've
I didn't
had
want to go to
enough?
detox, okay? I didn't want to go. I didn't want to make the phone call to go to detox. My boss forced me to make the phone call.
'Cause you didn't
my
wanna
job was
stop?
on the
You didn't
line.
wanna
No,
stop
I
drink-
just didn't want. I didn't think I needed to go. I didn't want to
Okay.
go. When I went down to detox, I didn't want to drive down the Gosnell. When I got to the front door, I didn't want to walk in. When I walked in and I sat with the nurse, I didn't want to go to the back room. And when I was sitting in there, I was thinking, what am I doing in here with a bunch of alcoholics and drug addicts? And it was that night, a commitment came in, a group of people who expressed their experience, strength, and hope. And something hooked me that night. And I realized maybe I'm in the right place. And then and the next day, when I went into treatment, and that we sat down and talked about treatment and addiction and a disease and the mental craving, the physical obsession, all of that, I learned about all that there. And I learned about what yets are and things like that. And I said to myself, that resistance I had 24 hours prior to that, it was a little different in there. And when I got out, after 7 days, they suggested things I do. And I did the suggestions because I didn't want to go back. And it was difficult. And it was difficult for a while because you have to change. You're changing as a human being. And you have to change. You got to think about this now.
Friends.
Your friends are all
Yeah.
drinking with you. Your friends are all using with you. Your whole world is at Melnina and Mass Ave. Your whole world is the bar you drink at. Your whole world is in the room you use in. And you don't think there's another way of life. And over time, slowly but surely, piece at a time, you realize that your life's different. And then you fast forward, years later. And when you talked about the prison situation, I know people personally that went into prison, went into Walpole State Prison, addicted human beings. And today, they're working. They have a family. They bought a house. They have a car. They have a life. All of that stuff. Because they were able to at some point, they were fortunate enough to get the recovery component of addiction.
Yeah, I'm going to say one more related thing, though, if I can, and then we're going to get to the calls because the lines are full. John, this is really for you. I can't tell you how many calls Marty and I have had over the last decade, and you've heard them, all of you, much more than we, from a mother who said, my kid was ready. I couldn't find a bed. All I did was I spent 24/7 trying to find a place for my son who was finally at the point, and I just couldn't do it. And often those stories ended with horrible sadness. We are still short on that front, despite the best of intentions, are we not?
Yeah, so when we talk about beds, there's different levels of beds. So the first entry for most people, not all, is detox or acute treatment services, and that's a 24/7 medical unit. We now have enough of those beds in the Commonwealth.
We do.
What we don't have is the long-term step down. And a lot of folks feel that the step-down beds are too expensive to have out there, but to the mayor's point, if somebody's whole world is somewhere where everybody's active and they don't have any other social supports, you have to remove them from that and put them in a safe, supportive environment, and that's where the long-term residential recovery homes can really play a role in keeping people off the streets and into recovery.
Let's go to the phone calls.
Before we go to the phones, the mayor will pick them in a second, but can you give us the Long Island
Yeah,
kind of update? Because you broached it before. And
This is where Long Island comes in. We are building a comprehensive campus on Long Island, but it is about long-term beds as well. And that's where this comes in. And I think that when you think about somebody who goes into treatment, some people need the halfway house. And I didn't go to a halfway house. I jumped right into the treatment. But I know people that need the long-term treatment. And if the bed's not available, I've called John before, and I'll say, John, I have somebody looking to get into treatment. Well, what's the list like? He'll say 10 people before him, or or I'll call Judy McDonough down there doing the Martin House in Brockton, and she'll say, there's 7 women before her. And that 7 women, that means that person has to go to holding. And if that person's in holding for 10 weeks, they're probably not going to stay there. Right. And what happens is now they think they can do it on their own. They go back out, go back home. They return right back to where they were, and they're not ready for that.
Who pays for the long-term beds?
State licensing.
The state pays for some of them, and then some of them can be privately paid.
Right.
Insurance. Insurance doesn't really pay for them.
Well, Mass Health
Mass
now
Health
pays
does.
for the residential.
But
So-
if you're
so-
not on Mass Health, then you got to hope that your insurance pays for it, or you got to shell out the money. As so many people
If
say
somebody's
themselves.
uninsured, the Department of Public Health will pay.
Okay, but if
TCH
they're
will
insured,
pay.
you hope you
Yes.
get something from
Yes.
Blue Cross or Pilgrim or whatever it is.
So I view Long Island as an opportunity to be a therapeutic community. It's on the water. People would go to work. People that go to the Gavin House go to work. And we want to build a bridge to allow people the opportunity to have that long-term care. Where we are in the process, real quick, we can talk about it next time on the radio. We're working through the DEP to get permits, and we're also working through, we have, I think, 1 court case still left. And I'm hopeful that we're going to be successful. We are planning the bridge. The money's in the budget. We're designing the bridge.
Are you talking to the mayor of Quincy at all?
We talk very, indirectly about it. I mean, a lot of what the mayor has a couple communities that are put pressure that they don't want it. I wish they would just think about it. Anyone in the areas of Quincy, like Squantum and other places, I know there are people in recovery in those neighborhoods. We're not looking to create a manufacturing site there where there's going to be thousands of cars every day. We're looking to put long-term recovery beds, people reclaiming their life.
So can I make a suggestion here if we can? We have a lot of calls. Let's take a break. When we come back, we'll not only get to the phone calls, we'll also talk about other solutions in the pipeline that may have some challenges that maybe we can deal with.
Okay, we are going to take a break, but we are talking about the opioid crisis with Mayor Marty Walsh, John McGann, and Marty Martinez. We're going to take your questions and calls. We promise, as soon as we come back, you're listening to 89.7 WGBH from the Boston Public Library.
People are just talking about the personality of these candidates, what they like about them, what they bring to the Democratic Party.
Clay Masters from Iowa Public Radio is one of the 4,000 public media journalists who provide trusted local coverage from all over the country.
And I talked to several people who had said that they had seen this person and they were still wanting to see this person. They're still winnowing their top 3 or 4 candidates.
Listen for reports from Iowa Public Radio with Joe Matthew, only on WGBH's Morning Edition.
Support for our programs comes from you and Worcester Art Museum, featuring Flora in Winter, a 4-day floral design extravaganza with art-inspired arrangements in galleries throughout the museum, January 23rd to 26th. More at worcesterart.org. And the National Trust for Scotland Foundation, USA, connecting Americans with what makes Scotland unique, from cottages to castles, from art to architecture, from wildlife to wilderness. More at ntsusa.org.
Welcome back to Boston Public Radio. Jim Browdy, Mark Dregan. We're live from our GBH studio at the Boston Public Library. If you're just tuning in, we're hosting a special, we're calling it an opioid summit, but it's beyond opioids, with Mayor Marty Walsh, John McGann, President and CEO of the Gavin Foundation, Marty Martinez. Marty is the city's Chief of Health and Human Services. We're now going to get to your calls. The number's 877-301-8970. Mr. Mayor, why don't you take one?
Rachel, our first call. Rachel Sudbury.
Hi, Rachel.
Hi, everybody. Jim and Marjorie, I love your program.
Thanks.
Thank you so much for all you do.
Thanks.
Thank you.
I'm calling because I am a parent coach for parents whose kids struggle from substance use disorder. And I volunteer through the Partnership for Drug-Free Kids, which is online, drugfree.org, and it's 855-DRUG-FREE. And anyone can call free, and they can, parents can talk to hotline support about their kids who are struggling. And then they can also get parent coaching support from people like me who have experienced my child struggling with substance use disorder. And I can help parents to fight the shame and stigma that's so associated and keeps parents and families so isolated with this disease. And so I just wanted to put that out there.
Rachel, what's the number to call? So if parents are listening, they want to help, get some help.
Yes, it's 855-DRUG-FREE, 855-378-4373.
Thank you, Rachel.
Okay, thank you.
Thanks a lot, Rachel, for calling in.
Let's go to Jody in the car.
Hi, Jody.
Hey guys,
Hi.
Thanks for taking my call.
Sure.
I just wanted to talk about compassion just a little bit. That's what all addicts need. And there's this common idea that comes up from people who don't understand addiction of addicts making their bed and now they should lay in it as if they deserve this misery. And there's two things I want to say about that. First of all, there's a whole chunk of people who are addicted who never made a bad choice or had a moral failure. You know, they were taking their prescription as prescribed, or whatnot. But even so, you know, we've got to have compassion for everyone. Everyone in their lives has made a mistake that could put them in danger. And addiction works the same way. You know, you can end up in an environment or even just make one mistake that leads you where you're going. It doesn't mean you're not worthy of compassion. And when it comes to food stamps, it doesn't mean you're not worthy of food, or your kids shouldn't get food. So I just wanted to put that out there.
Jody, thank you.
Thank you guys for having this conversation.
Thank you. Any reflections on that, gentlemen? Anybody want to comment, or just go to the next call?
I think a lot of people, I mean, are eligible for certain services as well. So we try to connect them to the services that they're out there. So I appreciate that. Ellen in the car.
Hi, Ellen.
Hi, I have a question, and I might be completely wrong, but I was under the impression that doctors, like your primary, couldn't prescribe methadone or Suboxone if you were addicted. Am I correct? You have to go to a facility?
You have to go to a facility for methadone. For Suboxone, primary care physicians and psych NPs who have been waivered, taken a class and been waivered to prescribe it, can prescribe it from their primary care office, as well as Vivitrol can be administered in primary care as well. It's just the methadone that you have to go to a clinic.
But there also should be a component of like programming with that as well. So you're not just taking the pill, but you're understanding about why you're taking the pill, what's going on with you. And that's one of the things I think that sometimes doesn't happen across the board. It does happen, but I remember Suboxone, if you go to a Suboxone clinic, there's a component of there's a component of counseling with that. And I think that that's key to it as well. You know, because it does work. I mean, there's no question it works. All of these, if somebody's not putting a needle in their arm, there used to be a probation officer at Southie Court. There was a move at the State House years ago to eliminate methadone, and I was kind of for it because I thought it was just chaotic. And this guy Jack Larry, court officer, probation officer, grabbed me and gave me an education really quickly, saying that I would much prefer to have somebody weeding off of heroin than putting a needle in their arm and causing crime or dying. And it made me think a little bit differently, a little more openly about it. And I think that on this on the medical assisted treatment, I don't think it's the only way to go, but I think it's definitely something we should be using.
Ellen, thanks for the call. You know, can we stay on the prescription thing for a minute? Another calls we've gotten on the other extreme is when the state put some limit on first prescriptions, and there was all the talk that gentlemen and women like you have had. People have called and said for their loved ones who do need these kinds of drugs that so many doctors are now gun shy because of the regulations, because of a whole variety of things. What do we do? You're nodding in agreement, John, that it's an issue. What do we do about this?
Well, we hear that as well, and I think it's a balance, and it's unfortunate that it's come to this, but when there was so many pills out on the street, the Commonwealth had to do something to try to rein in who was prescribing it, how many they were prescribing at a time. And we have to look at some of the crime that could have gone along with that. For example...
Oh, but by the way, let me just interrupt. They're not complaining about what the state did. They're saying because of what the state did in this whole big debate, doctors are pulling back even further than they legally have to because of the whole... You know what I mean?
Yeah, and they're trying to make sure that they're not over-prescribing to their patients and want to see them more frequently to make sure that the level of pain and the level of medication they're giving them is appropriate, and to make sure that they're not getting the innocent person, so to speak, addicted. I mean, you know, we talked earlier about people suffer injuries, get put on the medication, and become addicted. If they're giving somebody too long of a prescription, then that's the risk you run. And I don't think that we want to... think that it can't happen to the elderly who's shut it in. It can happen to them as well. So I think that the doctors are being responsible.
Does the average doctor have the training that they need to deal with this issue?
Up until 2014, there was no real training process for addiction. Now some medical schools say we did it, but there really wasn't. There was a piece of legislation that went through the legislature. The governor filed it. The legislature passed it. That has now a component of disorder or addiction. The explaining to doctors the complexity and the addiction that's caused by some of the opioids. So the training's there now. It wasn't prior to 2014. There was no official training. There might have been individual training going on, but it wasn't across the board. Today now, per the legislature and the governor's office, there's training going on.
Marty Martinez, you were shaking your head. You're going to disagree with the boss over
No,
there, Mr.
no,
Mayor?
no. But what I was going to say is that still today we hear hospitals say that although primary care physicians can get a waiver to be able to administer MAT, that they still don't get folks who want to do it. And I think there's a correlation between if you're in medical school and got very little training on how to prescribe and what does it mean to help someone dealing with a substance use disorder, then you're going to be weary about now what you see and kind of what you can provide. So even today, we have even community health centers who'll say we have one doctor who's willing to prescribe, but that's not enough to actually give enough people the care that they need.
By the way, the voices you hear for this special hour at the Boston Public Library is obviously the mayor of the city of Boston, Marty Walsh. John McGann is the president and CEO of the Gavin Foundation, and Marty Martinez, the voice you most recently heard, is the chief of health and human services for the city of Boston.
Mr. Mayor, before you get back to the call, just one quick question. I know you've got a Narcan, I think, in every public safety vehicle in the city, which is a great thing. So
We actually have
people-
training now in City Hall, so a lot of our team in City Hall, I think department heads and a lot of people are trained in Narcan.
But I know you've been in favor, or I think you weren't in favor, but now you are in favor of these safe injection sites that can prevent people from dying.
Yeah, I mean, it's one of those things. I was at a meeting one night, and somebody was talking about their journey in recovery, and the person just said, well, they weren't talking about safe consumption sites. They were talking about just any entry point into recovery is an entry point into recovery, and that hit me very differently. And I started thinking about safe consumption sites. And, we went up to Canada, Marty Martinez and myself went up there, and we started looking at the different facilities in Canada. And the thing that jumps out at you is that they've never had a death of an overdose of somebody using inside one of these facilities. Now, not everyone's gotten to treatment either, but they've never had a death. And the obituaries you talked about earlier, no mothers had to write one. And I think that, we should be looking at every opportunity as a potential entry point into recovery. And the safe consumption sites are one of those opportunities. I mean, there are people, and I'm one of them as well. When Suboxone first came, I was kind of like, well, I don't know, you should go the abstinence way and go to treatment and things like that. It doesn't work for everybody. I mean, everyone's different. Everyone's recovery is different. Everyone's entry point's different. And I looked at that as an opportunity, and I think that, everyone says, no, we don't want them. Before you say you don't want them, let's take a look at them and see exactly what it means. And I think that, there's still work to be done. There's still illegal in the federal government, and in this, they're not legal in Massachusetts either, or any state in America. So we have to really think about it. But it's been successful in Canada, and it's been successful in some European countries. So I think if it's working there, why wouldn't we look at what's working?
We should just put it in context quickly before we move on to the next call. Is the governor's not yet convinced that this is the right idea? And as you mentioned, Andrew Lelling, the U.S. Attorney for Massachusetts, has made it clear that, as of the moment, as you said, it is against federal law. He contends, and he will not tolerate in any case. That's the current state of affairs. Let's go back to the calls, Mr. Mayor.
Let's go to Mendez in Foxborough.
Hey, Mendez. Hello, Mendez. I think it's our fault. Can we get to Mendez on that line there, please, back in Brighton?
I guess
Are we having technical problems, people? We got to
There we
know.
go, there we
Mendez,
go.
you're on. Thank you. Hi.
Hello?
Hi,
Mendez.
Our fault. Hi, Mendez.
Hey, that's all right. How y'all doing today?
Great.
I'm trying to make 2 points here. So first is the stigma and the shame of the drug addiction. Nobody really understands. Like, at the end of the day, people goes into drugs in every type of way, not knowing the true consequence of it. But once you do decide to clean yourself up, you go into these halfway houses or treatment programs. When you come out, you have nowhere to go. So you're gonna end up right back on that staff, and it's more than just treatment. It's what's the treatment after the fact, after you get treated. Like housing, for example, where they have nowhere to go afterwards, so they're gonna end up on that staff regardless.
Let's have the mayor and others, if they choose, respond. Mr. Mayor?
Well, I think, there's definitely some issues with what's going on with the housing crisis and finding housing to go. But for all intents and purposes, when you go into treatment and you go into a halfway house, you should be working with the counselors there. And again, I'll speak for John for a minute, the Gavin Foundation. They'll set you up. While you're in treatment, you're getting a job. And while you're getting a job, you're rebuilding your life. And after you're done with your stay at the Gavin Foundation, there's an opportunity to go to a step-down program, or there's an opportunity to maybe take the next step. And I think that it's about working the program. And I think that at some point in your recovery, you have to, I don't want to say you're on your own, but you have to take responsibility for who you are as a human being. And I think that that's why the longer-term treatment is key to success. Again, there's no playbook to how this works. It's different for everybody. And I mentioned the story of the person coming out of prison, out of Walpole, that had no place to go, got into treatment, I think went to the Gavin House, went somewhere into a halfway house in Boston, and then was able to get a job, and was able to get a permanent job, was able to get his daughter back in his life, was able to buy a home down the road. And I think it's about rebuilding a life.
But to follow up on Mendez, Mr. Mayor, I'm sure there are some people who need more support.
No question.
In those moments. And is that there, John? Or
So it is there. So most recovery homes, long-term programs, will have caseworkers and counselors that will work with people while they're there. Part of the services that we will refer people to, if we don't provide them, is employment counseling, job training programs like the Access to Recovery, the Building Pathways. There's a slew of training programs out there, Pine Street, et cetera, where we try to get people employable while they're in the program, allow them to save money while they're there. They can then go into, a lot of programs have graduate houses they can go to, and then there's certified sober homes that people can go to, and they all, once they're at that point, they will have, be hooked up to insurance, Mass Health Insurance, and they'll have access to a recovery coach who can help them through the transitional phase and as they leave formal treatment and go into more self-help.
for the average person, if I may, either the individual themselves who needs the treatment or a family member, loved one, who is overwhelmed by the whole thing, which I assume almost everybody is, are there navigators either within the Office of Recovery Services or at the Gavin Foundation or wherever where they can talk to you about all the elements of this thing rather than you having to fish around by yourself? Do you know what I mean?
Yeah, the Office of Recovery Services is putting that together, but once you get into the treatment piece of it, it's incumbent upon the programs that they go into to help them. But let's just, as Mendez talked about, just people listening, not everyone, I think when my first day, my first group I had in detox, they asked us to describe the alcoholic. And what we all described was a person drinking out of a brown paper bag, a homeless person. That's not just the alcoholic. I mean, there are folks that go into treatment that have a job. They have a family, they have a life, they have all that stuff, and they've lost it over time, which means that if they're able to get into the recovery side of it, most times that all comes back. And you don't feel it at that particular moment, you don't see it at that moment, but it all comes back. So not every single person that's going into recovery needs food stamps, needs public assistance, needs a job, needs training. They have it. They need to rebuild their life. And I think that, so the addiction is so much more than what people view an addict or somebody suffering out there.
Marty, you want to add something?
No, the only thing I was going to add is that something that we're working, that John McGann and the Gavin Foundation are working with Recovery Services on is this STEP pilot. And the reason I lift it up is I think it's an example of exactly, to the mayor's point, as part of even our Mass and Cast plan, the STEP pilot sort of does that. It gives someone like the ability to navigate through the entire, like, you may be on the street, how do we get you to that first step of what it is to get treatment or care? How do we wrap ourselves around you, like case management? Do you need job training? Working to ensure that we might find you employment while we're also helping you navigate a service provider for housing. You know, we're also talking about, and John mentioned this, we're talking about lots of different providers throughout this. We're not talking about one entity usually doing all of it. So, and even in that, we're working in collaboration, but as you can imagine, getting from someone from off the street to actually into a job and with usable skills, it takes a lot of coordination and a lot of support. But again, that's only one group of folks battling substance use disorder. There are many other folks that are in different situations doing it, but that's a part of the work that we're doing in collaboration.
And are the numbers the mayor gave before, the 311 and 635-4500 to 617 number, those are the entry points for the kinds of things you're talking about in the city?
That's the main number at City Hall. The people, you call there for anything you want, but if you have an addiction question or you have a family member suffering, or you're suffering yourself, you call those numbers. We will then connect you to a counselor.
Fine, let's go back to the phones. Mr. Mayor.
Claudia in the car.
Hi, Claudia.
Hi.
Hi.
Can you hear me?
We can, yes.
Hi. So I just wanted to say I think this program is great. I graduated from Marathon House in 1974, so I've been clean, 40 years?
Congrats.
So one of the things that baffles me is that why can't there be places like Marathon House that were here in the 70s? They had 7 houses. They were a therapeutic community. They graduated up to 20 people a year, and a lot of those people are clean. I mean, I run a multi-million-dollar company. One of my people I was there with was the CFO of Citibank, the assistant district attorney in Springfield. There was a lot of successful people, but it was a 3-year program. You had first stage, second stage, and third stage. You know, recently I had to put my son into treatment, and I was appalled. I couldn't find a place. He ended up in some place in New Hampshire that was terrible, and now he's sitting home. He can't find a job. He, is with Mass Rehab, but they don't really help too much. So my question is, what happened to those therapeutic communities we used to have back in the 70s, number one? And number two, as a parent, how do you get, when you're in crisis and you need to find a place, where do you call to find a place? It was mind-baffling to not be able to find a treatment place.
Gentlemen.
Jen, thank you for the call, Claudia.
Thank you,
On the
Claudia.
second part of your question, I'm going to let John answer the first part. In Boston, if you live in Boston, you call 635-4500 or you call 311. And we changed in 2015. We realized that parents didn't know where to turn to. Well, we knew that before that, but we didn't have a hotline in the city of Boston. We have one out today, and we'll connect you to A-HOPE, which is a program that we have, and then we have providers that we work with to get people into treatment.
John.
In the Commonwealth, statewide, if you go to the Massachusetts Department of Public Health Bureau of Addiction Services helpline, they have a navigator there that can help you find everything from detox to long-term programs, outpatient programs, and it'll tell you whether or not it's publicly funded or private funded, so I would suggest that you go to that site. And as far as the long-term programs, what's happened is, I believe it's mostly driven by cost and capacity. Unfortunately, if you can turn a bed over in 6 months opposed to a year, then you can essentially intake twice as many people. So when we look at the number of people seeking services, we've been forced to, shorten the length of stay and try to get as many people into treatment and get them on the path to recovery, and then hopefully conduct a warm handoff to somebody in the community that will help them with community services.
Claudia, thanks for your call. We appreciate it.
One of the things, you see these ads on TV, the Globe did a series about this, places that are advertising recovery services, and they're in some beautiful beach in Florida or something, and then they were talking about how they really weren't doing such a great job at these places. So that's a problem too, figuring out where to go, right?
And what's real and what's a fraud.
Because you can pay tens of thousands of dollars, and you're not at a great place. What do you do?
I think you use the resources at your fingertips that people don't realize that are there. Not enough people understand that, whether it's the state line or the city line, to find out, even if you have a question on a program that you want to send your child to, or somebody or you want to go to, just call the city or state and let's see what's going on. There's some great programs outside the Commonwealth. There's some great programs here, but I would always tell parents. I mean, I've talked to plenty of parents that have paid, the tens of thousands of dollars to send their kid somewhere else, and it didn't work out for them. I always tell them, like, try and get somebody who understands. Even if you call a place in Massachusetts, just to ask questions. I think a lot of people will be open to giving you input and ideas on what's out there, what's not out there.
Well, let's go back to the calls.
Albert in Framingham.
Hello, Albert.
Hi.
Hi.
I'd like to first say thank you for providing the service to us so we know what's going on in our state. And as a veteran, I have some concerns being over in Afghanistan and having some of our NATO allies protecting some opiate fields and burning down others. So I see a point of vested interest. And then you guys talked about an article a while back how we had insurance companies bringing in people from other states to receive treatment. But my question is, do we have the infrastructure to do that, and who's profiting on this? Is it the insurance companies that are having these, what I would call heroin broker, bringing people in from other states.
Wow.
Albert, let's.
Because I love the idea of being a Commonwealth state, but I feel like we're being taken advantage of a little bit through the insurance companies if we're bringing people in and using our tax dollars to help them.
Let's get John to answer the question. John?
So very good question, and that goes back to capacity and when we talk about different types of beds. So first, it's not the insurance companies that are creating that. That is private enterprise that's allowed to come into the Commonwealth and open up a facility because there's no determination of need. Anybody can come in, they can get it cited, they can get a license, and they can open up a program, and those are being funded through private insurances, but they might not even be Commonwealth insurance companies. It could be insurance companies from Pennsylvania, North Dakota, wherever across America. They can fly them in and send them in. So it's not really, a lot of those private ones might not be serving Massachusetts people. The issue that they really create is a workforce shortage for programs that are here that are designed to take care of the people in the Commonwealth. So that's something that we want to keep an eye on.
Albert, thank you much for the call. We only have a couple of minutes left. Could we go down the line, starting with you, Marty? What's the one thing on your agenda, or at least on your list of things that you think could have the most major impact that we haven't quite gotten there? You know what I mean? I mean,
Yeah.
the thing, and forget politics just for a second.
Okay.
What would really make a difference?
So I'll leave Long Island just out there because
Okay,
we know
fine,
that
okay.
that was talked about, but I think that would make a huge difference. I think the thing that is making a difference and will continue to make a difference is really fully wrapping ourselves around individuals and not just assuming that our system's not seamless right now, so people are not easily able to access one level of care to the next level of care to the next level without extra supports. And so we've started doing that on a really small basis from getting you off the street into those sort of pathways to care. We've started, but it's small, and I think that's where we're making progress. It's complex. One person's story is as complex as anyone else's. So to do that, I think, and scale it is a big deal. We right now have the largest outreach team focused in the city. The city has that team. And so we're on the street working that every day, and I think we just need to keep doing that to get more people into care.
How about you, John?
So first, I'd like to say that the city is doing a great job trying to outreach to people and get them in. We have to understand that there's a difference between need and want. And so there's many people that need treatment. There's even less that want it, and the city's outreach team is doing a heck of a job really trying to drag people in. So that's one. The second thing is we have to understand that this is a disease of isolation. So how do we, as the chief mentioned, wrap people around, get them all the services they need? But we have to understand that many of these folks are very depressed, and some of it's situational depression. I mean, their life isn't going well. So how do we help them get job training, get jobs, get the things that need? Everybody wants to feel good. Everybody's basically looking at them like they're bums, and that's how they feel. And we need to be able to help lift them up and see their self-worth and carry them to the next step if we have to. But they can get there, but they need our support. And I think those wraparound things are very important. We would like to reach out to employers if you're going to be employer friendly and to people in recovery. I'm sure the mayor's office would be happy to handle those calls and share
Thanks,
it with
John.
those of us that are placing them.
You sound like Jim Browdy now.
Before we get to the mayor to finish up what his one, the reason I was smiling at you when you said there's a difference between need and want, when Andy Card was with us, former state rep in Massachusetts, who went on to become chief of staff to George W. Bush, we were talking to him. You probably don't remember this, Marjorie. And I said, when everybody comes and says they need a meeting, what did you say with the President of the United States? And his response was, I would say there is a difference between need and want. Which, Mr. Mayor, what's the top item on your agenda?
It's investment. What we're dealing with today has been going on for forever with addiction. The opioid crisis fast-tracked the heroin addiction in this country. Hundreds of billions of dollars was sold and made in this industry, and we're fighting it with tens of millions of dollars. So it's about investment. Everything we talked about today, whether it's Long Island, whether it's about further treatment, whether it's about getting people into treatment, it's about investment. And when you look at, and John won't say this, and he's never complained to me about this, at least in the last 5 or 6 years, but when I was on the board of the Gavin Foundation, the Gavin House, the amount of reimbursement was pennies to compare to the treatment that was given to somebody. So if we want to treat this correctly, we need to make investments. We need to invest in our people. We need to invest in the people that are sick and suffering, and that's the bottom line. Also, we need insurance companies to treat this like every other disease, and have, if somebody's diagnosed with cancer, the insurance company pays for everything to get that treatment. When somebody has addiction, sometimes they're put in detox for 5 days. That's not going to do it. We need to have better programs for insurance companies as well.
Gentlemen, we want to thank you all. We really, really appreciate your time today.
Thank you very much, and apologies we didn't get to all the calls and emails, but we've been speaking with Mayor Marty Walsh, John McGann, President and CEO of the Gavin Foundation, and Marty Martinez, the city's Chief of Health and Human Services. Mayor Walsh, John, and Marty, thank you very, very much for coming in. Up next, we're going to talk to Emily Rooney, famous list of fixations and fulminations. Keep your dial on 89.7 WGBH. We are broadcasting live from the WGBH studio at the Boston Public Library.